pay attention to this. If you have told that yes today, so this is really important because these are the things you will be definitely getting. Maybe in the short case you can move from here and there. In the long case you can miss some of the things. But these are the things, the tables that I am going to discuss will be giving you 100% marks. 100% marks. So let's start with the brain death declaration. Again, hot topic, mark fetching. Examinees make mistakes, and I strongly recommend that you should be simulating in your units prior to examination. Whatever you say, whatever you do in the real exam, you will be little bit be confused how you are actually presenting. Okay, now everything would be case scenario based. There is no theory. Okay. 40-year-old male was brought to the ICU after a severe traumatic brain injury following a road traffic accident. He was intubated at the scene, brought to the hospital in a GCS of 3, E1, BT, M1. Bilaterally dilated, non-reactive people. Very standard question. CT scan done, diffuse cerebral edema with effacement of the basal cisterns and transtentorial herniation. Clear? Now the patient remains deeply unresponsive 48 hours post injury despite full supportive care. The ICU team suspects brain death and initiates the formal assessment. This is the case scenario that was given to you in your exam, and from the ICU team, you are the person who is going to examine this patient for brain death declaration. Now, in the real exam, the examiner would be expecting that you have to go or maybe demonstrate what you will be doing at the bedside. Okay, I will be just be revising what you normally do. Now please proceed. Structured Viva. What is brain death? There are certain things I will be also asking you questions and also showing how you should be presenting at the bedside. What is brain death and how does it differ from coma and persistent vegetative state? Anyone? Straight question, straightforward question. What is brain death? Absent brainstem reflexes. Okay. Brain death is the irreversible cessation of all functions of the entire brain, including the brainstem. It is legally recognized as death. This is the basic difference between brain death, coma, and persistent vegetative state. While coma is a deep unconscious state where brainstem function may still be intact and there is potential for recovery. Now, what do you mean by persistent vegetative state? This occurs when the brainstem functions remain intact, but there is no awareness or cognitive function. Patients may have sleep-wake cycles, spontaneous movements, eye opening, unlike brain dead patients. Clear? So, the first question in the brain death, the examiner may ask you, differentiate between brain death, coma, and PBS. Now, common mistakes also I will say. Somebody can be confused brain death with coma and PBS. So there are certain smart answer for extra marks when you will be saying that brain death is a state of complete brainstem failure, as Dr. Gautam has cited, while PBS patients have preserved autonomic function. So differentiation is important for brain death versus PBS. Why? Why the examiner would be very keen on knowing that you are not dealing with PBS? Because this is for ethical and also legal decision making. Brain death is for legal decision making. Now, before starting brain death testing, what conditions must be met? Question. Answers please. As soon as you answer, then my next slide will be coming. What conditions must be met before starting brain death testing? So that means the examiner is actually expecting that you should know what are the prerequisites for brain death testing. Clear? What are the prerequisites for brain death testing? So before brain death testing, as you have all mentioned, reversible conditions that can mimic brain death must be ruled out. Now the first one is established irreversible brain injury of known cause. In our patient, it was RTA, traumatic brain injury. Now, the second point, no confounding factors. In this hypothermia, core temperature has to be more than equal to 36 degree. There should not be any sedative drugs and paralytics effects. So confirm the drug was out with T half-life calculations, shock or severe metabolic derangements like BP more than 100 millimeter mercury, sodium, glucose, pH correction has to be there. There should be no neuromuscular blockade. So these are the confounding factors you have to rule out, and there has to be established irreversible brain injury of known cause. Now, common mistake when the examinee not mentioning that brain death cannot be declared in patients with drug intoxication, severe metabolic acidosis, or hypothermia. So, if your patient is really suspected to have drug intoxication, you should not declare brain death. Clear? So, this is something which you should remember. The examiner may try to confuse you. Okay. Severe metabolic acidosis again. Hypothermia. Patient was received from a, I would say, frozen maybe pond or river or a lake, and you are thinking to declare brain death. No, you cannot do. Till the temperature is actually right now above the core temperature is more than 36 degree or so. You have exclude other confounding factors. You have waited significant time so that the drugs that has been the patient has ingested that has washed away. Okay. Now, there are certain smart answers for the extra marks. EEG or somatosensory evoked potentials may be useful if you are suspecting the patient is having drug toxicity or metabolic derangements. In these cases, maybe you should be going for the ancillary tests to support your diagnosis. Now, the next question, how do you confirm brain death clinically? Answers, please. Clinically. Cranial nerve, okay. Apnea test. Anything that comes to your mind, but yes, it has to be validated. Okay. Clinical examination of brain death is not about apnea test to start with. Clinical examination is a standardized neurologic examination that would be demonstrating irreversible loss of all brainstem reflexes. Clear? Now, these are the bedside brainstem reflexes that you should be uttering in front of the examiner. If you are not able to answer or utter these reflexes, the examiner would be completely furious. Pupillary reflex, how you are going to do it? What is the expected brain death finding? Corneal reflex, how you are going to do it? What is the expected brain death finding? Oculocephalic reflex, what is its other name? Whether it is normal in the normal person or not, how you are going to demonstrate at the bedside, what will be the expected brain death finding, oculovestibular reflex, otherwise named as cold caloric test, what you will be doing at the bedside, what are the expected brain death findings, gag reflex, cough reflex. Wow, you are going to do gag reflex and cough reflex, and what will be the expected brain death finding? Clear? This would be the clinical examination of brain death. Now, common mistake when you fail to mention that spinal reflexes like triple flexion may persist in brain dead patients. Clear? So you should know. The examiner may ask you. There are certain movements you are getting in your patient, whether this patient is brain dead or not. So spinal reflex may be present. Now, smart answers by you all smart people. Brain death doesn't affect spinal cord activity. Sharp movements like Lazarus sign may occur due to residual spinal function, but these are not signs of the brain activity. These are the activity from the spinal cord, and that can happen, that can be there in the brain dead patients as well. So, these are the smart answers. Now, what is the apnea test and how is it performed? Can anybody tell me? I know it's a little bit lengthy question. Answer. So step 4 is apnea. Step 3 is the clinical examination. Now apnea test. Why you want to do apnea test? The examiner may ask you. This confirms the absence of spontaneous breathing when carbon dioxide levels rise. So this is the normal physiology. When the carbon dioxide level rise, the patient automatically goes for the spontaneous breathing. Now, what are the steps? I know everybody knows it. I am just summarizing it. Pre-oxygenate for 10 minutes. Disconnect ventilator. Provide passive oxygen. Monitor the chest or abdominal movements for 8 to 10 minutes. Check the FBG. PaCO2 must rise more than 60 or by 20 millimeter above baseline. If no respiratory effort, the test is positive, confirming brain death. Now, there are certain common mistakes the examiner may try to know from you whether you are so confident or not. Stopping the test if hypotension or hypoxia occurs and calling it positive. So if your patient, when you are doing the apnea test, now the BP has fallen to 80 systolic and saturation is 86%, whether you should call that apnea test is positive? No. And what will you do if you are test coming as equivocal or inconclusive? A failed test means the test is inconclusive, not positive. Clear? I hope you are all very much clear in this concept. Now, smart answer: apnea test should be aborted if your SpO2 drops below 85% or MAP less than 60 millimeter mercury. And in these cases, alternative confirmatory test should be used. It's not that apnea test is not done, then you cannot declare brain dead. Clear? So these are some of the, I would say, clinical snippets that you should be knowing. Now, are confirmatory tests mandatory? Questions? Answers, please. Are confirmatory tests mandatory? No. Anyone who says yes? Okay, perfect. Okay. So, confirmatory test and documentation not always needed if clinical criteria are met, required when clinical tests are unreliable, that is, in drug intoxication and facial trauma affecting reflex test. When you are unable the oculocephalic oculovestibular test because of this faciomaxillar maxillo injury, and you are unable to do this Doll's eye reflex and other tests. Now, common confirmatory test. What are the confirmatory tests? Cerebral angiography. You will be getting no cerebral blood flow. EEG, no brain activity. Transcranial Doppler, absent diastolic or reverse flow. Now, common mistake: stating that the EEG is always required for brain death diagnosis. It is only needed in special situation. And some smart answers. Now, different countries have variable protocols. Like UK doesn't mandate confirmatory test, but Japan require additional test before declaration. Clear? Now, final takeaways for high marks: stepwise structured answers. What is the definition? What are the criteria? What are the tests? How will you document? What are the ethics associated with the brain death? Avoid common mistakes. Use global perspectives. Understanding international guidelines can impress examiners. Clear? Now, how do you approach the family for brain death declaration and organ donation? This is again very important. The examiner may expect that you have actually declared brain death and you know how to disclose this, because this is something breaking bad news also. Okay. So you have to know about the legal and ethical aspects. Discuss with empathy. Use simple language. Avoid pulling the plug, all those phrases. Legal death declaration. Time of death is, the examiner may ask you, when the second assessment confirms brain death, not ventilator disconnection time. When you have done the second time assessment and you are confirming that yes, this patient is brain dead, so that is the time of death, not when you are disconnecting the ventilator. Discuss organ donation sensitively. Rather, I would be suggesting, and also this is the norm also, you should be, rather you must involve transplant coordinators. You should not be discussing about organ donation in the same setting of brain death declaration. Now, common mistake: saying we will stop life support now. No, because brain death is legal death and no further treatment is possible. Okay. Brain death declaration in India. The examiner, as you will be all appearing for DRNB exam, which is an like no Indian exam. So in India, what are the acts that you should know? So this is THOTA, Transplantation of Human Organs and Tissue Act, THOTA 1994, and there were two amendments, 2014 and 2019. So you should remember this act to 1994. And the Indian Act differs from international protocols in examiner requirements, number of assessments, and mandatory documentation. Can anybody tell me how many examiners are required for brain death declaration in India? Okay, interesting. Two, four, five. Somebody has written five. Dipanshu. Very nice. Group of four. Okay, simultaneously everybody will come. All the four people. 4, 3. Very interesting. So we have only the options remaining are 1 and 6 because 2 has already taken 3, 4, 5. Anybody? Any taker for 5? Look, this is something you will be definitely getting in your exam. And the number of assessments, 1 or 2 or 3 or 4, 2 assessment. Okay, good. So this is something everybody is clear. Okay. I will be discussing that also. Don't worry. Lot of things are there. So just be patient. Okay. So legal requirements are in India. Conformity tests are needed only if clinical criteria cannot be fully assessed. It is Indian law. Four doctors must independently certify brain death. Who are the four doctors? ICU in charge, registered medical practitioner, neurologist or neurosurgeon if they are unavailable in your ICU or in your hospital, intensivist with neurology training, treating physician, government appointed doctor for organ donation cases. You have to involve your NOTO. Okay. Now, two independent brain death assessment must be done 6 hours apart. Now, the examiner would be asking again, what is the time of death? Time of second brain death confirmation. What is the form that you need to fill up? Form number 10, that is the brain death certificate, must be filled under THOTA. Now, smart answer, India follows a rigorous process with 4 independent doctors and 2 tests to ensure a robust, legally valid brain death declaration. Now, what are the ethical and family communication considerations? Explain sensitively the things that I have already told, and organ donation discussion must be separate and voluntary. This is in India context. You cannot discuss at the same setting. Organ donation also. Common mistake. This already I have discussed with you. Now key differences. This is in the like one like the table that you can get. Number of examiners 4. In UK, US it is 1 to 2 senior. Number of tests 2 tests 6 hours apart. Here 1 to test 2 tests 6 to 12 are apart. Confirmatory test not mandatory, often required. Time of death second test declaration time. Legal framework THOTA 1994. Organ donation link declaration separate from donation. But in UK, USA they can just do like no at the same setting only. Clear? I think the questions, everything related to brain death have been discussed in detail. Did it make sense? Now you should be very confident if you are getting. Look, this is the law. If the treating physician is a neurologist or neurosurgeon, I think he can tick it into both the cases. No, treating physician also, he is the treating physician, admitting consultant, and also neurology or neurologist. Okay, so anyway, your requirement is fulfilled. But in case there is some confusion, there have to be 4 person. He can invite somebody from his team also to be another person. Okay, from the neurology department or neurosurgery department. Okay, clear? Now the second part of our brain death. Now everybody is clear. If they can perform in the real exam, you need to do it in your unit before the exam, just very systematically. What I have actually explained. It hardly took me 15 minutes discussing everything. In the real exam, they will be also expecting you to discuss everything in 5 to 10 minutes. So if you are very sure, you can answer quickly. Now, how will you manage a case of organ donor rather than I would say brain dead organ donor in your ICU? Again, case 35-year-old male with severe traumatic brain injury following a road traffic accident is admitted to the ICU. Despite all efforts, he meets brain death criteria after two examinations performed 6 hours apart by four independent examiners as per the THOTA guideline. Clear? The family has agreed to organ donation and the ICU team now needs to manage the donor to preserve organ function. Clear? Why ICU management of an organ donor is important? Any answers? I request all of you to don't leave the discussion because anyway, you all are making me talking for 3 hours continuously. So I should be expecting also some dedication from you. Okay. Dyselectrolytemia, optimal transplanted organ survival, organ function, preserve organ for maximum viability of organ harvesting, preserve organ, endocrine function. Very good. All of the things have been correct. So I'm just trying to summarize. General principles of organ donor management. Look, all my answers are actually in a very much stepwise manner. If you have till now understood, I am using the step or the approach to that particular thing in a stepwise manner, and also the questions are also coming in that way. So this is a two-way process for the examination also and how you should do at the bedside. Now, brain death leads to progressive physiological instability due to hypothalamic and brainstem control. So, proper management in ICU optimizes organ perfusion, preventing ischemic injury. This would be ensuring maximum number of viable organs for transplantation. It maintains hemodynamic stability, avoiding hypotension, hypoxia, or metabolic dysfunction. If you answer these 3 points, the examiner would not be asking you any further question. I'm giving you guarantee. Now, common mistake, somebody saying brain death is the same as cardiac death. No, because still the circulation is ongoing. It is only the brain death. Okay, so the goal of ICU management in brain dead donors is to maintain multi-organ perfusion, optimizing transplantation outcome. As simple as that. Clear? What are the common cardiovascular changes after brain death and how do you manage them? Questions, answers, please. Hypotension, arrhythmias, okay. You are all no bubbling with knowledge at this point of time because you recently have appeared your theory exam. You are prepared very well, so I expect that you should be just vomit. Don't vomit in your room. Anyway, this is not affecting my laptop or my position here, but yes. So step 2 is hemodynamic management. Brain death causes catecholamine surge leading to hypertension first. Remember, it is a bimodal presentation. Hypertension first followed by profound vasodilatation and hypotension when there would be brainstem death. The medulla and the pons, the blood flow will be less. Arrhythmias and myocardial dysfunction due to catecholamine storm that already you have answered. And how will you manage? Volume resuscitation, crystalloids first, normal saline or ringer lactate, vasopressors and inotropes. In the vasopressors, the first choice is noradrenaline, vasopressin is the second choice. Cardiac dysfunction, dobutamine or milrinone. Your target should be monitoring the MAP more than equal to 65. to maintain adequate organ perfusion. Now, always noradrenaline, never you should say dopamine because these patients are more prone to have arrhythmias. Now, how do you optimize lung function in a brain dead organ donor? Any answers? Lung. First heart, already it is over. Lung. How would you manage? Fluid restriction, lung protective ventilation, LPV. Okay, good. Very good. So you all are like ready with your answers. Okay, pulmonary management. Brain death leads to neurogenic pulmonary edema, atelectasis, ventilator associated pneumonia risk. Your ventilator strategy should be lung protective ventilation, FiO2 less than equal to 40%, recruitment maneuver because these patients are more prone to have atelectasis and minimize barotrauma. You should not be going for high PEEP because this patient may land up in pneumothorax and in that case it would be difficult for you to go for lung harvesting. Okay. Now, oxygenating with FiO2 100, they won't go for over oxygenating. These patients also expect all like you should be very sensitive to like not have Vili. What are the common endocrine disturbances in brain dead donors and how do you manage them? Now, answers should come thick and fast. Thyroid, hyponatremia, DIE, hypothyroid. Okay, very good. Okay, good. Okay, hyperglycemia. Okay, endocrine and metabolic arrangement. Why this happens? Because hypothalamic pituitary axis failure happens, leads to hormonal deficiency. Three things you should say. Diabetes insipidus. Mechanism is ADH hormone is actually deficient, leading to polyuria and hypernatremia. Treatment is vasopressin, 1 unit IV bolus, then infusion at zero point 0.5 to 2.4 units per hour. Cortisol deficiency. Why? Adrenal insufficiency due to loss of ACTH from the hypothalamus, pituitary. Treatment IV hydrocortisone 100 milligram IV bolus, then 50 milligram Q6H. Sometimes you can go for solumedrol till 1 gram also. Thyroid dysfunction, T3, T4 deficiency. Again, the ideal replacement is T3, that is IV liothyronine. But yes, if you do not have, you can go for the oral thyroid hormone replacement. Here, the thyroid hormone replacement is not for like the replenishing the thyroid dysfunction or taking care of the thyroid. Rather, it would be helping for the myocardial dysfunction. So, thyroid is actually helping to get better contractility of the heart. Clear? Now, common mistake, overcorrection of sodium too fast. Agar in DI, if you are actually going for overcorrection, it is like no dangerous. Rather, vasopressin corrects DI while improving the systemic perfusion by reducing vasodilatory shock. Okay, vasopressin is actually preferred in DI. Why is temperature control important in brain dead donors? These are all the things that you should be answering in your exam. Temperature control. Brain dead donor. Bleeding, ICP maintenance, coagulopathy, sepsis. Okay, good. Brain death abolishes thermoregulation causing hypothermia and that would be reducing oxygen delivery, worsen metabolic acidosis. And what is the management? Passive warming, active warming. Target temperature should be between 36 to 37 degrees centigrade. The mistake is ignoring temperature control that would be leading to systemic dysfunction. So you should be always going for like no the warming if necessary. Now, what electrolyte imbalances occur in brain dead donors and how do you correct them? I hope everybody knows about it. The nutritional and electrolyte management, hypernatremia due to DI, hypokalemia due to polyuria, hypocalcemia, hypomagnesemia that would be affecting the cardiac function. Now the correction approach, sodium correction, aim less than 12 millimole per liter for 24 hours to prevent cerebral edema. Potassium again you have to maintain between 4 to 4.5 for myocardial stability. Magnesium and calcium replacement has to be there to prevent arrhythmias. Now overcorrecting the sodium lead to cerebral edema. So you should always go for slow correction of hypernatremia. When should organ retrieval be planned after brain death certification? Any answers for this question? Okay. Timing and logistics for organ retrieval. Organs must be retrieved as soon as possible, and this should be coordinated by transplant team and NOTO. What is NOTO? National Organ and Tissue Transplant Organization. This is very important. They may ask you all this like no these short names also. What is THOTA? What is NOTO? What is SOTO? All these things. Okay. Now, common mistake they may ask you as an ICU or like a team member, are you responsible for organ retrieval logistics? No. ICU team only stabilizes the donor while NOTO and the transplant team handle the retrieval. Clear? In India, I have already told what are the things that you should remember. In like no people like no they expect that family consent is not needed, maybe in Western countries, but in India, though the patient previously has given the will that yes he wants to be a donor, but till now explicit consent from next of kin is mandatory in India, so you have to involve the family. Clear? So India follows a strict legal framework under THOTA requiring 4 doctors and explicit family consent before organ retrieval. Clear? Now we are over with brain death and management of the organ donor. Clear? So now it is breaking bad news. Should we break the bad news now? We should be all expecting good news from you. Okay. Rather, I would say this is related to the issue how to break the bad news. Again, there would be all clinical scenarios, and I will be summarizing everything you know because you have all appeared your theory exam successfully cleared. So it would be just revision. Scenario: 45-year-old male with severe traumatic brain injury has been declared brain dead. You have to inform to the family. The family is really hopeful and waiting outside to hear some good news from you. Okay. Now the examiner would be giving you this type of scenario in your exam, practical exam. Now how you are going to handle or break the bad news. Always in your exam have a structured answer approach. So here you can use spikes protocol. So you will say to the examiner, I will be using the spikes protocol, and in that A stands for setting. I will find a quiet place, ensure privacy, have a nurse or a colleague present. P for perception. I would be asking to the family relative, what do you understand about your loved one's condition till now? I. Invitation. Would you like me to explain the latest findings? K. Knowledge. Use very, I would say, simple language. Now, what will be the language in this patient? The brain controls breathing, heart rate, and all body functions. Now, after repeated test, there is no brain activity because you have already declared brain dead. This means he has passed away even though the ventilator is keeping his body functioning. E. Empathy and emotions. Be silent after you explain till now. Allow them to react. Acknowledge emotions. I can see this is very difficult. I am here to answer any questions. Now, S for summary and support. Offer support, bereavement counseling, religious or spiritual help, and you should not be discussing. Rather, it is your transplant coordinator or the team from the NOTO would be discussing the organ donation if appropriate. Finished. So this is something if you would be discussing or answering in this fashion, the examiner would have anything to ask you again further. Clear? Any questions at this point? No. Okay. Now the second clinical scenario, a 68-year-old female with metastatic cancer and multi-organ failure is deteriorating despite full ICU support. Now you have to discuss with her daughter to transition to the comfort care or palliative care. How would you approach? Can anybody just suggest how would you approach in your exam, real exam? I am the examiner. I have given you this clinical scenario. Anything? EOLC care protocol, end of life care protocol. Okay, okay, good. So I hope you all know. So I'm just trying to summarize. Now this would be, I would be using the nurse protocol for empathy. So there is a protocol and the mnemonic is N, nurse, the N, name the emotion. I can see that you are very worried. You understand the emotion. Anyone in your position would feel the same. Or respect. You have been making the best decisions for your loved one. S, support. We will ensure she is comfortable and pain free. This is important because you are now going for comfort care. So S for support. E, explore options. We have reached a point where aggressive ICU care is causing suffering rather than helping. Would you like to discuss a more dignified approach with comfort focused care? So that means you are actually exploring the options. You have not decided that you are going for the comfort care. So very good empathy protocol, that is nurse protocol, which is easy to remember. Now, third one, a 55-year-old man with severe COPD has failed multiple extubation attempts. You have to explain the need for prolonged ventilatory support via tracheostomy. That means you have to explain to the family about tracheostomy, how we are going to do it. This is also a very, I would say, commonly asked clinical scenario for breaking bad news or counseling or communication. Now, the structured answer approach, I think we all know. I'm just trying to summarize it quickly. Explain the situation in simple terms, that this patient, your father, has been on ventilator for several days, his lungs are weak, and despite whatever we do, it is difficult to remove the breathing tube and he cannot breathe well on his own. Give a rationale for tracheostomy. You can draw a diagram also. A tracheostomy, how it is safer, more comfortable way to provide long-term breathing support, and how it would be helping to reduce the risk of further lung infection, and the patient, your father, would be more awake and comfortable. You also acknowledge the concerns like tracheostomy is not the treatment. So I understand this is a big decision, but we will support you with more information and help you understand what to expect. And finally, discuss the prognosis and next steps. Don't leave the person like in the middle of the way that yes, we'll do the tracheostomy. After that, nobody knows. No, this doesn't mean that he will always need a ventilator. It gives him the best chance for recovery in the prevailing situation while preventing complications. Simple. So these four lines, if you would be explaining to your examiner, do you think you will give less than 10 if it is the full mark is 10? Okay. Now, question, the scenario number 4. 40-year-old man admitted with septic shock had a sudden cardiac arrest despite full resuscitation. Now, you have to inform the family about his death, about the cardiac arrest. How we are going to do it? Now, ABCDE framework I will go with. A for awareness. That means I have some very difficult news to share to start with. Don't just jump and run to the family and say your family, your member, like no family member is dead. No, B for brief explanation. What happened? What happened? The sudden cardiac arrest, code blue, all these things the family would be hardly understanding. So you have to explain despite our best efforts, his heart stopped suddenly and he did not respond to the resuscitation. Now see, you have to clearly at that point explain or announce that the patient is no more. I am very sorry, but he has passed away. Then after that, definitely you will expect the family would not be taking it so lightly or casually. So you have to demonstrate empathy and give a period of silence. Pause. Allow them to process because you have actually broken like bad news. So I cannot imagine how hard this is for you. And finally, after that, explain what happens next. Discuss postmortem formalities, support services, also offer time to see the body. You will be inviting or taking the family members or the person in front of you to the bedside to show that yes, we have done our best. Now the your family member, your beloved member is no more, and the family would be also somehow be convinced that yes, you have given your best attempt by doing the CPR. The CPR cart would be there, the ventilator is still on, all the things. Okay. Now, next scenario, complication. How you are breaking the bad news. A 65-year-old male was intubated, needed a central venous catheter. After the procedure, he developed a pneumothorax requiring chest tube insertion. So you have done everything because you didn't have time to call the family. The patient had pneumothorax after putting the central line, and you have again immediately put the chest tube. Now you have to inform the family that that has happened. Now, I would be using Spikes protocol for this. S setting, find a quiet place again. All the same thing. P for perception. Then you have to explain what happened today. Before I explain, can you tell me what you understand about today's procedure? Is that person aware of the things that we have put the central line and the requirement of central line was this and then something has happened, so you have to know the exact knowledge or awareness this relative has. Otherwise you would be starting with we did the procedure and then we had central the pneumothorax, then the family must have previously got the information, so it would be repeating this thing, or maybe the family would be having less confidence on you that you are a complete new guy who has not known to the family or has not seen the patient also before. I for invitation. Would you like me to explain everything in detail? And then when you observe that yes, this person doesn't know anything, then you have to explain clearly. A for knowledge. And in that you have to explain in very simple language. During the central line insertion, a rare but known complication. This word is very important. A rare but known complication. This is not something which has been done for the first time in my ICU today. No. So this is called as pneumothorax. What do you mean by pneumothorax? Don't leave or use these medical jargons. You have to use pneumothorax, and in after that air leakage in the lung that has occurred. Again, you have to give the exact statistical analysis of pneumothorax post central line. This happens in about 1 to 2% of cases despite precautions. We identified it immediately and placed a chest tube to remove the air, and he's stable now. This is something you have to explain to the family, that it's not that we have done something mistake and we have not corrected or we have not tried to correct or rectify. So we have done all the things necessary post pneumothorax also. Now, after this, you have to be empathetic and emotional. I understand this is distressing. We took immediate steps and he is being monitored closely. E. And finally, summary and support. I am offering you to answer any questions you have, and we are taking all the precautions as well as the steps that to prevent further complications in our ICU or hospital. Clear? So this is in short Spikes protocol. Now the next scenario, something no, I would say angry family relatives when you are disclosing something. A 35-year-old patient with sepsis suddenly deteriorated and passed away within 2 hours coming to your ICU. The family becomes angry and threatens the staff. Okay, accusing them of negligence. They are saying that your team has done terribly wrong. They have not diagnosed my case properly, and they have done something for which my patient who came here walking and talking, and now you are saying that this patient is no more. So these are the some of the very, I would say, relevant clinical scenarios. The examiner may try to put these type of things, and they would be expecting how you have dealt with this type of similar cases in your training period. So be familiar with these cases. Don't be surprised when you are getting the similar cases in your practical Viva exam. Okay. Now, there is a Lassie method for conflict resolution. Lassie? What is Lassie? L for listen. First, don't argue with the family relatives because something has happened. They are angry and they are trying to threaten the staff. And they are now saying that you have actually neglected. So allow them to express their emotions without interruption. Be silent. Just like listen to them. Stay calm. Acknowledge their pain. Do not argue or become defensive. This is something the examiner would be expecting from you. Example, I can see how devastated and frustrated you are. This is really a heartbreaking moment. So you have to be empathetic and also feeling the same like the family relatives. You cannot like say, and this is maybe a normal thing for you, but for the patient's family, it is something like for them, it is like no, the patient is something very close to them. Now, second, Lashy LA, acknowledge feelings. I can only imagine how hard this is for you. You trusted us with this his care, and I understand that this outcome is very difficult. Yes, now after this, try to be practical. Till first LA, you are showing emotion, but now for the S, separate facts from emotions. You cannot combine the two things. Explain in simple words. Despite all efforts, his infection was too severe. Otherwise, they will be killing you, the family relatives. So you have to say that this patient came with septic shock, with high vasopressors. You intubated, you have done everything. So you have to mention this also that his infection was too severe and his body could not recover. Our team worked tirelessly, but unfortunately, some infections become too overwhelming. So these wordings are very important to impress the examiner. So try to keep all those things for the examination point of view. If you use these words, it would be just like no Rohit Sharma or Virat Kohli is like no cover drive. Okay. Now S, stay safe. Now, after this also, the examiner would now create a problem for you. They would say, after this also, the family is behaving really aggressively and they are like no trying to beat you or like no some of your juniors. What will you do? So the next S would be stay safe. If aggression escalates, you have to immediately call your security, hospital administration staff for de-escalation and keep a safe distance but remain professional. Don't get to the mob and try to handle that on your own. You have to have a team. Your hospital representation has to be there. Now, immediately they would be threatening you, we will be killing you, we will be murdering you, something like that. So inform about next step, like offer post-mortem or case review if the family insists on explanations, and end with support. Sometimes trying to be sympathetic to their problem also will make them realize that yes, this doctor is understanding, he's also or he or she is emotional also, and he also feels that this is something happened very unfortunately. So something we need to go in a very systematic approach. Lassie. Now the next one is again how to explain after cardiac arrest everything you have done, but there is no brainstem reflex, and you have to explain how you are going to do for the brain death declaration. Already explained, so I'm not going to detail, but these are something which you need to know. Explain the situation clearly, what has happened. Explain the prognosis that despite 72 hours of treatment, he has not shown any signs of waking up. This is very important, and you have done all brainstem reflexes testing that suggest very little chance of meaningful recovery. And then you have to offer support, acknowledge the emotions that I understand this is difficult news. Many families hope for recovery, and we always give every possible chance. And then, if they would be going to the next discussion, definitely you should be going for palliative options to ensure comfort and dignity. Now, again, Junior doctor, your team member's error has led to worsening infection. So, like your doctor should have given the antibiotic at middle of the night at 12 a.m., but the doctor has not prescribed. The patient has not received one dose of antibiotic. Next day morning, the patient died, and the family had checked the medication chart, and they didn't have the they didn't get the antibiotic that was actually given to the patient. Now they are now demanding answers as you are the ICU head, or you are the in charge, or you are the attending at that time, and your junior doctor has done something which was not expected. Again, so there is a Pearl's framework for medical error. This is a medical error. Definitely, this is something which was fault from your team. Okay. So P for partnership. That means I want to be completely transparent about what happened. Don't hide anything at this point of time because they have already seen your medication chart and this has not been prescribed as well as given by the nurses. E for empathy. I understand how upsetting this must be. I want to assure you we take this very seriously. That means you are authoritative at this point of time. You are taking it very seriously about that this is a medical error. Acknowledgement of the error. An antibiotic dose was delayed, which may have contributed to the worsening of infection. This should not have happened, and we regret this deeply. This has to be there. The examiner would be expecting that you are hiding or you are actually explaining in a very much politeful way and you are regretting deeply. So, if you are acknowledging the error, then the examiner would be very happy. Now, R for response. How we are going to fix it? We have corrected the issue immediately and escalated care. Our team is monitoring closely to ensure no further errors occur. Now, if the family relative will ask you, the examiner would now tell you that the family member is saying, no, we want a review to be done by the high officials of your hospital and strict action to be taken against you as the team leader and your junior doctor. So then you have to go for L, legal and institutional follow up, and you have to explain to the family, yes, we are conducting an internal review and will take steps to prevent this from happening again. And finally, support and solution for the family. I assure you that this will be formally reported and addressed. Offer to discuss with a senior administrator if needed. You have to involve your hospital administrator also. Now, last I would be, I think this is the last scenario for the breaking bad news. Again, how to break the bad news of withdrawal of life sustaining treatment with the family because you think that continuing treatment for a 74-year-old patient with severe ARDS with MODS on maximum life support is futile. Now, this is again ethical framework for end of life decision. E for E. Try to remember. Now, E for explore understanding. What do you understand about your loved one's condition? T for truth telling. Despite your best efforts, his organs are failing and his condition is not improving. Human connection and empathy. I can see how difficult this is for you. Involve family in shared decision making. The examiner would be expecting you to use this sentence, shared decision making, or this word. Now, clarify treatment withdrawal process. Don't give all those medical jargons that withdrawal of life sustaining treatment, WSOT, all those things. No, explain that stopping aggressive interventions doesn't mean stopping care. Rather it would be giving the persons the comfort care. Address spiritual and cultural beliefs and long term bereavement support. Again, something last, I think this is high grade glioblastoma. Surgery is not an option. Prognosis is poor. So you have to inform the patient and the family. This is again the spike protocol. You can just use it. MRI shows a brain tumor, and I know this is very difficult to hear, and you have to give the options. This is something ECMO. How you are going to discuss about ECMO for a patient with severe myocarditis on maximal inotropes and ventilatory support, but deteriorating. Explain why ECMO is needed. First point, discuss the risk and benefits, and set realistic expectations. Don't like give hope that if your patient is on ECMO, then definitely he or she is going to improve. No, even with ECMO, recovery is uncertain and we will reassess daily. Finally, address families' questions also. If they want to know what is ECMO, how ECMO acts, all those things, you have to answer them and try to involve a multidisciplinary team. Lot of questions I have created for you. Wow. Okay, this is something related to pregnancy. I thought like no, this pregnancy and like no pulmonary embolism, amniotic fluid embolism. These are something very interesting for the examiners also. So, 34-year-old pregnant woman had cardiac arrest due to amniotic fluid embolism and is now on ECMO and mechanical ventilation with no signs of neurologic recovery. You have to break the news to the family. Approach, acknowledge the complexity, explain the neurologic prognosis, address the pregnancy aspect sensitively because the baby is stable for now, but we need to discuss how to proceed based on the mother's condition, and finally discuss family's wish and ethical consideration. So finally, the exam tips for breaking bad news: use a structured communication method, whether it is spikes or ABCD or nurse or pulse or lassie. Speak slowly with high pitch, low pitch, and like no modulating your voice. Avoid medical jargon. Allow silence in between. Acknowledge the emotions and never rush or like no post decision on the family. Offer realistic hope but set clear expectations. Involve multidisciplinary teams for complex cases. Maintain eye contact, appropriate tone and body language. Stay calm and professional even if the family is emotional or aggressive. Offer solutions, follow up plans, institutional support when appropriate, and if family aggression escalates, prioritize your safety and involve security if needed. Anything at this point of time? We are now over with the second one. Do we continue? How many of you have GCS 15 by 15 at this point of time? How is the Josh? Priyojit, tell me. You raised your hand. Okay. I want very high, not high. Okay. So should we continue? Yes. Okay. We'll continue. We'll finish everything. So still we have 45 minutes to go. Okay. So clinical audit scenario again. Everything is on scenario. Straightforward question for your exam. So the examiner, you entered into the examination hall and the examiner is now asking you or showing you a scenario that you are working as a senior ICU register in a tertiary care hospital. The ICU team has noticed a high mortality rate in patients with septic shock. The department head has asked you to conduct a clinical audit on adherence to the surviving sepsis campaign bundle within first 6 hours of sepsis diagnosis. Clear? Now, how would you go for audit for this case? Anyone? I will get some at least 1 minute break. Oh. Anyone who wants to answer this? No one? How will you go for audit for this case? Because high mortality rate in your ICU when the patients have been diagnosed with septic shock. Okay. So first you have to frame one title of the audit. Compliance with the 1 hour and 6 hour sepsis bundle in ICU, a clinical audit. Now, what are the background and rationale? You have to make it very clear. Why you want to choose this topic? Because sepsis is a leading cause of ICU mortality And as per the SSC 2021 guideline, they recommend early recognition and prompt management. Studies show that adherence, if you are going for the sepsis bundles, they reduce mortality significantly. Now, what is the aim of your audit? That you have to make it very clear. To assess adherence to the sepsis bundle elements in ICU patients diagnosed with sepsis or septic shock. You have to first assess the adherence. Then you have to identify the gaps and implement quality improvement strategy. First, you have to check what is the status, then the gap, and what are the quality improvement strategies that you can adopt. Now, then you should be having your standard and the criteria of the audit measures. Compare ICU compliance to the Surviving Sepsis 2021 bundle. Within 1 hour, what are the things you should do? Within 6 hours, what are the things you should do? You should have the standard criteria. What is actually as per the SSC campaign guideline. Now, what is the audit methodology you will be adopting? The design would be either you should go retrospective or you should go prospective observational study. Clear? What are the inclusion criteria? Who will be included in this study? All ICU patients diagnosed with sepsis or septic shock as per the sepsis 3 definition. Exclusion criteria, those who have already received treatment before ICU admission. Sample size has to be minimum 30 to 50 patients over 3 months. Data collection have to be through ICU case records, EMR or sepsis order set. If you are ordering for sepsis panel, definitely sepsis is in your mind. Now, what will be the results and key findings? You have to check the percentage compliance with each bundle element. How many patients in those 3 months they have been compliant, or your clinicians or the nurses have been compliant with their treatment, or the bundles have been followed up rigorously. And then you have to identify the common gaps, what have actually happened and what has actually led to failure of the bundles approach in your patient, and that could have resulted in high mortality. So the one would be delayed antibiotic administration, underuse of lactate monitoring or fluid resuscitation delay, or the patient to be shifted in ICU and the different other monitorings have not been done properly. Now, the conclusion would be a well conducted clinical audit helps standardize sepsis management and improve patient outcome. Continuous quality improvement measures are needed to improve adherence to the sepsis bundle. And what are the action plan quality improvement that you can do? Implement sepsis checklists at the ICU admission first. Regularly conduct sepsis awareness training for the ICU nurses and residents. Try to introduce early warning score and RRT to identify sepsis from the ward itself. And again, this is the first audit and you have implemented so many quality improvement plans. So again, you should go for re-audit after 6 months to assess the improvement. So this is the perfectly structured audit for your patients who are coming with sepsis or septic shock. Now some Viva questions. The examiner may ask you, how do you choose an audit topic in ICU? What are the topics that you need to choose? Anything or everything that is coming in your mind, or any specific criteria has to be there while you are choosing the audit topic? Yes, there has to be a standardized format for the audit topics. First, it has to identify high impact clinical areas affecting patient outcomes, and ICU is one of that. Focus on evidence based guideline, that the first one, no, surviving sepsis campaign we have selected, because definitely if you are doing it properly, there is a significant mortality difference. KDIGO AKI, again, if you are doing all the bundles as per the KDIGO guideline, definitely chances of patient going into AKI is less. Now, look at the frequent errors or variability in ICU practice. If there are multiple, the leads at which the treatment plan or care plan is getting compromised, you can do audit to check that. choose a topic where quality improvement is feasible. You can know, yes, there is a problem, you implement something, and then you can see, yes, the improvement is there. Now, what are the key steps in conducting an audit? The examiner may ask you. What I have already explained to you in the first one, this is summarized here. Identify the topic, define the objectives, set your audit standards based on the guidelines or the best practices, collect data, whether it is retrospective or prospective. Now, you have to analyze compliance with the standards in your hospital or in your ICU. Then you have to identify where is the problem, where is the gap, and then after that, after knowing the gap, you have to propose the interventions, and finally implement the changes by the training, by the the team squad. You can create, you can have nursing sepsis cards, code sepsis, all those things in our sepsis case, and conduct a re-audit for improvement. Okay, how do we ensure audit findings lead to clinical improvement? You have to share the results with ICU team and hospital administration, implement various interventions, training, checklist, protocol revisions, monitor compliance, feedback via regular follow-up, and conduct a re-audit after 3 to 6 months to measure improvement. Now, is there it's a foolproof system? Can you do any audit and you will get response and success? No, there have been definite challenges you will be facing in conducting an ICU audit. Why so? The examiner may ask you. Inconsistent documentation in patient records. We do not know when the patient is entering into emergency, when the patient is admitted to your ICU, when the duty doctor has first time seen the patient. Low adherence to the protocols due to our ICU workload, the nurse patient ratio, the knowledge gaps. It may not be always you will be there and you know the importance of surviving sepsis campaign guideline. Lack of institutional support, maybe you will not get the blood culture bottles at the right time, you will not get the option of doing lactate for your patients regularly, or there is some resistance to the change. Maybe the doctors are not very keen on sending the sepsis panel in the emergency department itself. Time constraints in a busy ICU environment, and data collection bias. If your criteria are not well defined, you are getting data, but this data is not actually the proper data that you are targeting. I think there is another scenario, but maybe this will be the similar to the first one. I'm just skipping this because otherwise will be too. This is something what I have already explained. The audit methodology is similar only. Then the results and key findings. Then what are the action plan for the quality improvement? This is related to the stress ulcer prophylaxis. How many patients have been receiving the patients appropriately? What are the patient percentage who are actually inappropriately getting the stress ulcer prophylaxis without any risk factor? So this is something, again, another audit that can be asked to you, or this is something a very much standard template that you should do. Okay. With this, we finish the third part, that is the audit. Now comes to the ICU quality indicators. How many of you are with me? How is the Josh at this point of time? Dehydrated, hypoglycemic, encephalopathic? No? Okay, perfect. Okay, the next very important thing is ICU quality indicators. So, general questions, I would be asking you some of the questions and then giving you a scenario. What are the quality indicators in the ICU? Can anybody tell me? 1111. Quality indicators in the ICU. Structure, process, outcome. Okay, very good. BAP, Donavedian model, outcome. Jagan is saying outcome. Sarbana is saying BAP. So if your examination will be happening and you will self extubation. So you are going from like no Antarctica, somebody is going to the Arctic, somebody is going to Africa, somebody is going to the Paris. So don't know how you are like no answering, but yes, it should always have a structure, Rumba model. Okay. So quality indicators in the ICU are measurable variables that help assess the efficiency, effectiveness, safety, and patient outcomes. These indicators are used for benchmarking and quality improvement. Now, can you categorize ICU quality indicators? That's the question that I asked you, and you have said your answers. Yes, they are categorized as structure, process, outcome. In the structure, nurse to patient ratio, availability of intensivist, process, adherence to the sepsis bundles, ventilator bundle compliance, outcome, ICU mortality, VAP rate. What are the key ICU quality indicators recommended by ACCM and WHO? Again, it has to be structured answer. Mortality related indicators, infection control indicators, patient safety indicators, efficiency indicators. Clear? So these are the some of the indicators that you have to answer in a very much structured way. Clear? Now, how do you measure and benchmark ICU quality indicators? So this is again a very favorite question from the examiner. Use standardized definitions as per the different guidelines. Regularly go for audit and surveillance. Benchmarking with national and international data like Apache form, SAPS, SOFA score adjustment, and C. SMR is in your ICU, in your like the different ICU units are actually at par with the standardized mortality ratio. Now, how do hospital acquired infections impact ICU quality measure? The hospital acquired infections increase the morbidity, mortality, length of stay, and cost, and they are very much crucial for quality assessments like CRBSI, BAP, or COUTI. What is the role of mortality prediction models in ICU quality assessment? This Apache 4, SOFA, SAPS 2, they help risk stratification and mortality prediction. And these are very important to go for benchmarking and quality improvement. Now, the examiner may give you one quality indicator, that is the ICU readmission rate. What is the significance as a quality metric? High readmission rates indicate premature ICU discharge. That means you are actually discharging the patients to the wards prematurely, and they are going for suboptimal management in your ICU, or post ICU syndrome is happening. So a 48 to 72 hour readmission rate more than 5 to 10% is a red flag. That means if out of 100 patients, 10 patients coming to your ICU within 48 to 72 hours from the ward, that means definitely your ICU discharge criteria has to be revisited. How does compliance with the ABCDEF bundle impact ICU quality? Now, what is ABCDEF? Assess, prevent, and manage pain. B for spontaneous breathing and having trial. C for choice of sedation and analgesia. D for delirium. Assess, prevent, and manage. E for early mobilization exercise. And F for family and engagement. That would be improving patient center outcome, reduces delirium, and enhances recovery. Now, how do you assess patient and family satisfaction? That is also a ICU quality indicator. Okay. This is by some of the scores: ICU family satisfaction score, FSICU, regular family meetings, shared decision making, post ICU discharge follow up survey. You can do this type of survey to know how many of your the patients' families, they are satisfied with your management, or they are okay with your family meetings. Now, antimicrobial stewardship program, definitely a very favorite question by the from the examiners. So you must have read for the theory. But yes, in the quality indicator, they would be asking how does antimicrobial stewardship programs improve ICU quality indicator? How? It reduces multi-drug resistant infection, decreases mortality and antibiotic associated adverse effects, and it optimizes empirical antibiotic use based on the local antibiogram. So finally, what is happening? You are reducing the infection, multi-drug resistant infection, and also antibiotic associated adverse event, and also overuse or misuse or underuse of antibiotics. Now, again, one more quality indicator is rapid response system in your ICU. How does it contribute to ICU quality improvement? By early warning system, MUSE or NUSE, reduce the unexpected cardiac arrest and ICU admission, code orange, and it enhances timely critical care intervention, just like the QSOFA score. So patient is not going into the proper sepsis, rather patient is being shifted to the ICU from the ward or STU before developing or going into the sepsis or septic shock. Now, one scenario just for your understanding, and the examiner may ask you what are the quality indicators that have been actually not followed up properly. 65-year-old male with sepsis secondary to pneumonia in the ICU. He was intubated and mechanical ventilated for 8 days. On day 10, patient develops new fever, leukocytosis, and purulent secretions. What quality indicators are relevant in this case? Can anybody tell me? In this case, yes, Prakriti told VAP bundle. Good. Yes, yes. Okay, good. VAP rate, antibiotic stewardship adherence, compliance with the ventilatory bundle measures like head of bed, elevation, DBT prophylaxis, oral care. What steps would you take to improve quality in such cases? Implement VAP prevention bundle judiciously. Early tracheostomy if prolonged ventilation is anticipated. Assess the hand hygiene compliance and appropriate suctioning technique. These are all quality indicators. Hand hygiene compliance also, suctioning technique also. Now, on one more the quality indicator case, your ICU reports an increase in the CLAPSI over the past 3 months. What could be the reasons for this rise? Poor adherence to the sterile precautions during line insertion, insertion checklist or maintenance checklist, inadequate catheter maintenance, line care bundles not followed, delayed removal of the central lines. What strategies would you implement to reduce CLAPSI rate? Full barrier precautions during insertion, daily assessment or line necessity and early removal, and antiseptic impregnated dressing and chlorhexidine bathing. Maybe some of the things that you can do if your CLAPSI rate is so high in your ICU. So in the examination, definitely the examiner would be asking some or other quality indicator. Now one more scenario, a critical care unit has an ICU mortality rate of 25%, which is higher than the national benchmark. How do you analyze and improve ICU mortality as a quality indicator? Any questions? Any answers for this? Your ICU mortality is 25%. Scoring. Restratification using Apache or SOFA audit case records to identify trends, what is happening, why your patients are dying more compared to the national benchmark, and implement multidisciplinary rounds and early intervention protocols. Your protocols need to be revisited. Maybe you need to redefine the ICU structure both in terms of the care delivery and also policy making. What are the ICU quality improvement methods? PDSA cycle: plan, do, study, act. Checklist, there has to be many checklists that you need to implement in your ICU. Do it judiciously, religiously, benchmark it with national and international data, regular MOMs, morbidity and mortality meetings. How do you implement a zero harm policy in the ICU? Strong infection prevention policy, strict hand hygiene compliance, regular RCA for the adverse events, no unnecessary central line sedation or prolonged mechanical ventilation. If you do not like go for these invasive procedures without a cause, very specific cause, definitely your patients will be having less complications. So maybe you can implement a zero harm policy. So these are some of the questions that the examiner may ask you from a clinical scenario that I have shared with you. Okay. Now the last part is conflict resolution. Do you have any conflict at this point of time? No? Perfect. Okay. The only conflict is that we need to finish it on time. Okay, good. Now the last part, I am starting with a clinical scenario. I have very good scenarios for this conflict resolution, and this would be a very, I would say, a demanding table viva in your exam. So they would be trying to give you a scenario, and there would be a conflict associated with that, and they would expect how, as an like examinee or a trainee, you are trying to solve that. So a 72-year-old male with severe ARDS due to COVID-19 is on prolonged mechanical ventilation with multi-organ failure. The ICU team believes further treatment is futile, but the family insists on continuing aggressive therapy. How will you approach? Anyone who can suggest? The family wants you should continue. You are thinking that you are actually wasting your resources, manpower, talent. Okay, good. Okay, so for this, acknowledge the family's emotions. Explain medical futility with clarity. Use simple terms. Introduce the palliative care team. Involve them. Discuss comfort focused care. Offer a time limited trial. Don't like no in the first meeting itself try to discuss about taking the tube out or withdrawal of the support system. No. Rather just introduce it for the first time. Give some time for them to digest. We can reassess in 48 hours and decide further, and involve the ethics committee or hospital legal team, because otherwise there is no point like no continuing for a patient with COVID-19 with multi-organ failure. Clear? Now, second scenario is different. Here there is a conflict in the team between the doctor and the nurse. An ICU nurse reports concerns that a doctor's decision to escalate care for a 90-year-old terminal cancer patient is causing suffering to her as well as the nursing community. The doctor insists on full aggressive treatment. So the nurse is complaining that as per the doctor, he is continuing with the treatment for a 90-year-old terminal cancer patient, and the patient is suffering as well as the caregivers are also suffering. But the doctor feels something else. How do you resolve this conflict? Anyone? You will have a meeting with the nursing team. Anyone? This would be a scenario also. In your like, no, this is between nurse and doctor. There may be a situation by the examiner that the senior doctor is saying to continue antifungal, and the junior doctor is objecting. No, this patient is not having any risk factor for antifungal, like no fungal infection, so we should not give the fungal treatment. So this can be a conflict also. In the examination, you will not be saying no that the boss is always right. Okay. Otherwise, the examiner would also say that as the examiner, I am also always right and I will be giving you a big zero. Okay, so for this case, acknowledge both perspectives. I understand your concerns about the patient suffering. Discuss the patient prognosis. Facilitate an interdisciplinary meeting. You will be involving the palliative care also and senior intensivist, maybe more senior to you. Use an ethical framework. Assess if treatment aligns with patient's prior wishes. Is there any directive or any will the patient has? And encourage mutual respect. Both perspectives aim for the patient's best interest. So it should be the final, the conclusion should be it should be for the patient's best interest. It's not for the doctor's ego or the nurse's like no own perceptions. Now the next scenario, two patients require the last ICU bed. Clear. This is again a very interesting conflict. A 45-year-old post cardiac arrest with good neurologic prognosis and a 78-year-old with severe sepsis and vasopressor. The emergency team pressures for the letter's admission that yes, this 78-year-old guy is known to the emergency team uh, chief. So what will you do? You want the 45-year-old post cardiac arrest patient because the patient had ROSC within 2 minutes and is having a good neurologic prognosis. How do you handle this bed allocation conflict? Anyone? Or you will be taking the patient that you actually like to. Okay. So follow ICU triage protocol, prioritize based on the survivability and prognosis, communicate transparently with the ER team, explain the triage criteria that yes, as per the triage criteria, the 45-year-old post cardiac arrest patient should be given the chance. Engage senior ICU leadership, multidisciplinary decision making. Offer step down care options if your ICU is full and there is a stable patient in your ICU who can be shifted to SDU, then you can be taking both the two patients and your emergency team will be also happy and you will be also happy. And document reasoning for accountability, like ethical justification why you are taking the patient, the first patient, not the second patient. Now, a 60-year-old post-operative patient developed sepsis in the ICU. Despite appropriate antibiotics, he deteriorated. The family accuses the team of delayed intervention. They are saying that because this patient was not given proper physiotherapy or position changing, that patient developed bed sore, pressure sore, and for that this patient has actually deteriorated and antibiotics also were started late and that has actually resulted in more and more deterioration leading to patient's death. How would you respond to such an allegation? I have already explained in our breaking bad news. Maybe similar to that. Remain calm and professional. Explain the clinical course with transparency. Don't try to hide the thing. Offer a mortality review meeting. Involve a neutral senior doctor and then address their emotional distress. Escalate to hospital grievance team if needed. But yes, maintain non-defensive stance. Don't try to defend your team or your role, like no, whatever you have done. A 55-year-old patient with metastatic lung cancer has a documented DNR order. The on-call resident, unaware of this, starts CPR after a cardiac arrest. Though it was written, do not resuscitate, but the on-call resident, he didn't know it and he started CPR. The ICU nurse protests initially, but finally the resident's lead was followed. How you do handle this breach in protocol? Next day morning when you came to the hospital to take the round, you got to know about all these things that has happened in the night time. So you have to reassess immediately that yes, there is the DNR status is properly documented in records or not. You have to educate the resident post event and discuss the ethical and legal implications if that has been already mentioned, documented DNR. How come he has started CPR? Strengthen the documentation process. Maybe all these things have to be prominently noted Conduct a debrief with ICU staff, review the lessons learned. Maybe the other staff members should be knowing about that. Yes, there may be the lapse from their side also sometimes, and implement DNR awareness training. Maybe they don't know that there is a concept called as DNR. Clear? Now, there are certain general questions that you need to remember when it comes to the conflict management. What are the common types of conflicts in the ICU that can happen? Conflicts in the ICU typically occur due to high stress situation, ethical dilemmas, and multidisciplinary interactions. The common types include interpersonal conflicts among the doctors, maybe in the same team, maybe in the interdepartmental, nurses and doctors, staff and doctors over the management decisions, ethical conflicts on the basis of end of life care, withdrawal of life support, or DNR order, communication breakdowns between the ICU and the family due to unclear prognosis explanation. There may be conflicts happen due to the resource based conflicts like ICU bed shortage, and there are like a lot of patients in the emergency department, in the ward, in the SDU. Ventilator allocation, maybe the patients are not getting ventilator timely, the BiPAP machine allocation, or prioritizing the patient care or the nurse patient ratio. All these conflicts may be there. Then decision making conflicts when the family members have differing views on continuing aggressive treatment. So these are the types of conflicts that can happen in the ICU. Now, what are the principles of conflict resolution in the ICU? Active listening. You have to first understand the concerns without interruption. As the critical care, like senior most person or senior person or responsible person, you should not be having biased answers. Rather, it should be having active listening first, clear, transparent communication, avoid medical jargons, explain all the situations, maybe to the junior doctors, to the nurses in the simple terms, acknowledge the emotions and distress of the patient's family and staff, try to have a middle ground rather than imposing a one sided decision. You have to take the consideration of all the sides that you are actually having, and escalation to the ethics committee or mediation. If still the conflict persists, never try to solve everything on your own. Try to have a neutral third party for the conflict resolution. How do we handle disagreements among ICU team members? Like one of your doctor is saying something and the other doctor is opposing, or they are having the idea that as you are the senior person, you are taking side of the other person. So address the issue privately, avoid conflicts in front of patients or families, encourage open discussion, allow both sides to present their concerns, mediate difference with a senior intensivist or team leader, prioritize the patient centered care. Whatever will be happening in the ICU, it should be for the best interest of the patient, not personal conflict or personal bias. And always have a structured conflict resolution model, the DESC model. What is DESC model? Describe, express, specify, and consequences. That would manage the disagreements constructively. You have to describe the problem, express the both side, the arguments or their points and counterpoints, specify the solution, the middle path, and again after that you have to check the consequences that can have in the patient management. Now, the legal and ethical aspects, I think everybody would be knowing this, and I think Darshan would be discussing tomorrow the ethics in the ICU part. I'm not going to detail. Now, the communication strategies. What are the communication strategies to prevent conflicts in the ICU? The examiner may be keen to know how you are actually handling the communication part in your ICU. So, daily structured family meeting, involvement of multidisciplinary teams, board meetings, then use of interpreters, language barriers should not be leading to miscommunication, shared decision making, and whatever you do in your ICU in terms of the discussion, transparency in the prognosis should be there. Now, this is the summary of conflict resolution approach. Step 1, identify the conflict, acknowledge the concerns and emotion, gather the facts from the medical records, triage criteria, ethical guidelines, engage the stakeholders, whether it is ICU team or the family or the ethics committee or legal advisors, offer a collaborative solution like seek a middle ground, and finally document and follow. So with this, we come to end of. I know it's a hectic evening, Saturday evening, maybe holy evening. You should remember forever if this would be coming to the holy when you are getting success this time in your exam. So confidence is preparation. Everything else is beyond your control. So with this, I come to end of this. I would say hurricane mammoth evening where we discussed in detail about two short cases, some of the suggested short cases, and five table vivas, which are very important. And if you answer well, it gives you the confidence, and also the examiner would not be hesitating to give you full marks.